I'd like to thank Dr. Cal and all of you and the organizers for inviting members of our Riley team back to be a part of this program. Thank you very much. I realize this may not fit with the general scope of the meeting, but despite being rather specialized care, many of you are going to have certain touch points with children and certainly young adults with congenital heart disease. And I hope to point out that you, in your practices, can really impact both the short and long-term outcomes. Just the customary picture of our institution. Presentation outline is going to be, we want to just briefly go over the prevalence of congenital heart disease and what the access to care is on a global level, outcome trends and congenital heart defects, factors that impact those outcomes and mortality, and then focus of integrated programs. We'll talk a lot about how we've set up our program back in the States. Not everything that we have can be applied elsewhere in the world, but there's certain principles that can be adopted by any program anywhere that does impact outcomes. Well, first, just to set this, in some perspective, if you look at this bubble chart, the size of the bubble represents the population of those countries. And across the x-axis there are the number of children with congenital heart disease per year in those countries. And then along the y-axis, the vertical axis, are the number of CV centers. This becomes important in that there's a huge global burden of children with congenital heart disease, but there's a great discrepancy on where you can get access to care. So in Africa, very few centers, high population, high rate of congenital heart disease, and then to the other extreme, the United States doesn't have near the burden of congenital heart disease relative because we have a smaller population, but we have one of the highest number of centers. So access is quite disparate. And likewise, there's a great disparity in the number of surgeons available in these populations to serve the children. In North America, it's one surgeon for every 3.5 million population. In Africa, it's one to every 38 million. So really, there's a vast number of diagnosed children. The global needs certainly extend beyond what medical charity and exchange programs can provide. Many can't access care, many can't afford care, and many programs aren't resourced adequately to maximize capability and achieve best outcomes. In countries with a history of developed programs, what do we know about the history of outcomes in those children undergoing repair? Well, in this chart, this is Norway. This has been a national, they've had a national registry for some time. And what we see is that there's a decrease in childhood mortality from essentially all congenital heart defects registered in the country. And this is representative of trends observed internationally among countries that have some developed program in congenital heart surgery. In the lower chart, you can see the number of deaths related to congenital heart defects has consistently gone down in those countries with developed programs. But even so, you have these programs and these defects are repaired. What you see here, the vertical dotted line, is the expected mortality for people without defects. So even with an ASD, there's a higher risk of mortality. And the more complex a defect, the higher the probability of having a mortality risk, even though we've done all these things with operating these children. And in fact, in this diagram, the blue is the mortality risk less than 1 year of age and then greater than 15. So in the early 50s, at the advent of all the surgery for children with heart defects, the mortality risk was really on the front end. But as surgery's gotten better and care has gotten better, the mortality has really shifted to the older population. And in our country, we now have 60% of the congenital heart disease patients are adults. and that's a growing population. So we've had a number of children survive their defect repairs, and now we have adults that have repairs, and they have developed into a whole nother population to try to work with. And just briefly to show you that the challenges with it, if you survive a Fontan, this demonstrates that those that have survived a Fontan at 40 years have a significant probability of 5-year risk of death compared to the general population. So as you take care of children with heart disease, they're going to transition into adults. There's not a lot of good care modeling out there for adults. So these grown-ups with congenital heart disease is a whole new population that's almost a specialty in itself. Well, what are some of the common factors that influence outcomes in these children? Well, the biggest thing fundamentally is genetics. We know that most defects have some genetic basis, most likely, and it's the higher risk in the first-degree relatives. And it's certainly discernible in 30% of the cases, and this is rising. A lot of work's going into looking into the genetic basis of congenital heart defects. What does that do? Well, the more we know, the more they can start to develop precision medicine. And this is targeted therapy, even for people with developmental defects, such as a heart problem. You can do earlier diagnosis. You may be able to create interventions. There may even be fetal interventions. Neurodevelopmental and cognitive disabilities are present in a high number of children with congenital heart disease. So all the children that you see in your practice, it's emerging as one of the most common comorbid outcomes in survivors with critical congenital heart disease. And it probably accounts for the majority of postoperative morbidity. You can't change the genetics, but the quality of the postoperative care can play into how these children do with their defects. And we do know that if you look at this, on the top is the brain of normal population, and on the second line are transpositions. I won't go into a lot of this, but basically if you look at the 4 components, 4 regions of the brain, look down at the bottom, and with the congenital heart defect brains, they tend to have anatomical differences in how those connections are between the different zones of the brain. So there's developmental abnormalities even in the brains of these children, and maybe it has something to do with how the defect impacted their development in utero. Well, there's new technologies, just briefly to talk to you about, with the management of children with congenital heart disease. One of them is mechanical circulatory support. So for those patients that you see with acute and chronic heart failure, there's a variety of devices being developed. This is a sampling of a group that was in a study to try to see which device might work the best. Well, it's high technology. Most of the children that are going to get this are really a bridge to transplant, so it doesn't have a lot of worldwide applicability, but the one device that probably is usable is the Berlin heart. Regenerative medicine and 3D printing of complex lesions is another area that's emerging. This is where translational research is impacting clinical care, and so there's a hope that we can do some kind of cell-borne changes with valve scaffoldings and things where you can kind of generate your own new valve and so forth. They're certainly doing that and starting to get into clinical practice. The other thing that's kind of interesting is you can take an MRI and do 3D modeling. You can make these plastic complex defects, and you can practice how you want to do the repair before you even do it on a patient. Well, this section will then go and just briefly focus on the characteristics common to the highest performing centers. The biggest thing to talk about is volume. There's a lot of evidence out there that shows you that the volume done by a center equates to outcomes. And in this study, if you look, it doesn't show up well, but there's a number of red dots right here. There's a number of green dots here. And so the odds of mortality in an institution, the over-under, is around 150 cases. So in this study, if you did fewer than 150 cases a year, you had a higher probability of having mortality risk with your program. If you did over 150 cases a year, your outcome risk went down. This is also backed up in a article that in this one said the outcomes or the risk of dying in hospital was much lower if performed in an institution performing greater than 300 cases annually. Another study revealed something very similar, but said that maybe the outcomes were different. It wasn't so much the incidence of complications, but maybe the management of those complications led to a worse mortality. So it's not just the surgical technique and doing a lot of them and having patients get to the ICU, but it's how do you manage these folks once they get to the ICU? It can result in morbidity, mortality. It's the one variable that we have that we can work on. The British programs, in Britain, no program is allowed to do fewer than 350 cases a year based on this kind of data. And surgeons who now do congenital heart surgery in Britain must perform more than 125 cases a year. This has led to improved outcomes in the British system. Well, all that data wrapped up leads me to what I want to talk to you most about, which is the integrated congenital heart service line. How do you bring these things together to get best practices, best outcomes? And we did this at our program, and I'll touch on some of the things that we've been doing. I look at it as kind of an embedded versus an integrated. The embedded is what most programs have or did have before they evolved to something more sophisticated with regards to targeted program management. So you have hospitals, and we were just the same way. It's a PICU, it's not a CV-ICU directed thing. We had nurses, we had floors that took all ages, all defects. You could have an ortho patient on the same floor as a neurosurgery patient. It was age-based and so forth. But with the integrated program, we had the ability to take a new hospital that was being built and build a program into it. And with that, we had specific cardiac ORs and actually put them across from the cath labs in a hybrid room so that we had a cohort right there. We had our own anesthesiologist, so it was a small team. We developed a CVICU, pulled it out of the PICU. With that ICU, we developed 24 hours 7 of intensivists. We talked the nurses into coming over being CV-specific nurses. They are dedicated to cardiac kids. We have the newborn unit. We've pulled the CV kids out of the newborn unit and have a CV NICU component module in our heart center. Step down, and we have a place for adult congenital. This has allowed us to have sort of an integrated team and one that can work off of certain care protocols. How we went about establishing the pillars were access, capacity, capability, throughput, and post-discharge. So we wanted a continuum of care, both coming in, making sure we had good skill sets, everybody dedicated to it, everybody watching what they do, assessing what they do, and so forth. This is the floor that we have, these two sides, and ultimately when it's fully developed, this is the CVICU. The ORs are just one floor below. Mechanical circulatory support, and we propose we'll have newborn ICU there, although they're going to be mixed in over here, and then we have this other side for adult cardiac step-down telemetry. The service line that we have, the core inpatient, is in the red, and everyone that touches this service line is dedicated to CV. Doesn't mean they can't go somewhere else, but they're held accountable to being CV specific. And then in the light green, those are all ambulatory centers of excellence that we have attached to the inpatient. So patients come into our system through the single ventricle, outpatient, aortopathy, genetics. We have a really growing population of those with pulmonary hypertension, and these are multidisciplinary clinics. And we have a number of committees that are structured in order to help manage this. And everybody that is involved, anesthesia, nursing, everybody in the service line populates these committees. One of the things that we do, and we do aggressively, is track and report complications, because these have direct impacts to morbidity. We look at central line bloodborne infection, UTIs, ventilator-associated pneumonia, surgical site infections. We look for pressure ulcerations, adherence to line care protocols. We have protocols for how you manage somebody on the vent, protocols how you manage somebody with a central line, and there's hand washing monitoring. I'll just go quickly through how we view these things. Every day there's a daily central line report. When was it put in? How was it managed? Did we manage it appropriately? And are there any problems with it? That leads to us being able to track how many infections we have related to central lines. UTIs, catheter-based UTIs. We do a stoplight report. Did we do well? It's green. If we missed our benchmark, it's red. Ventilator-associated pneumonias. Stoplight report's the same. Bundle compliance. Did we adhere to doing all that we have in our protocols to avoid any complications with those lines? And are there opportunities? So we look at all of our outcomes, we benchmark them, we look at hand hygiene. Did we hit our benchmark or not? That's another stoplight report. These things are very important in how you manage minimizing complications and improving outcomes. Well, what is that done for us? Well, one of the ways you self-assess your program is being involved in registries. We're involved in the STS Congenital program. There's 122 reporting centers in the U.S. 118 centers are included in the analysis because they have enough data. A number of those programs will also publicly report their outcomes. This allows you to do center comparison and publicly reporting. They will publicly report your outcomes based on expected. So the observed over expected ratio with 95% confidence limit. So it really exposes your program to how well it's doing. It's the largest pediatric and congenital heart database in North America. There's 97% participation. 11 programs get audited every year so that the data is as good as it can be. This is a distribution across the United States of how many people are involved with it. The darker the green, the more centers that are involved. So for the public reporting, they give you your mortality rates expected, and so this is for all to see. And you can compare yourself to other programs and how you are performing. They give it in a star rating as well. So a 3-star is the highest rating you can get. About 10% of the programs will achieve this. About 15% will achieve the 1-star, and everybody else is in between. Well, our service line has allowed us to see a continual decrease in our OE ratio. So this is how we assess how we've done with developing this integrated care model. And what you end up doing with the STS is they give you this diagram. Across the bottom is the volume of the programs, and you can see the confidence limits extending to it. So the mortality rate, the STS mortality, sorry.
2 minutes.
Okay. The STS mortality is this line here. And so these are all the centers that are reporting. This is when they give you your number and you can go in and see where you are. So this is our program relative to everyone else. And then they give you what your overall OE ratio is, and they give you your star rating. So this allows you to kind of see how you compare, and it also gives you reams of data on what your morbidity, your complications rates are as well. Let me just briefly show you something that we're doing with the single ventricle patients. This is a high-risk group. You know, historical mortality between interstage mortality is 10-15%. A lot of single ventricles have a lot of problems, but this is something you can adopt in your practice here. One of the things is doing a quality improvement collaboration that was started in 2008, and this was designed to freely share ideas between programs on home monitoring. This is where the number of centers that are involved. Home monitoring means we can try to get an idea of how kids are doing as an outpatient, and some of the problems with that is just getting them to record it. We started a program with the iPad, and what that does is the parents can go in, they log in, they have certain tasks that they have to do. Those tasks are registered. They can also give you photographs. These get downloaded, and then Ann Farrell actually runs this one with the hypoplast. And then you can go in, choose the patient you wanna see, you log on, choose the patient, what are the tasks for that day. You can see what the real-time data is, near real-time data. It also has an algorithm that will help acknowledge whether or not you're falling outside of what the expected is, so that maybe you can intervene. And so the questions, you know, will this help improve interstage mortality? Can the children be monitored more easily? Will it cut down on any unnecessary risks between visits to the hospital? So in conclusion, the components that, as we see it, of best outcomes in programs are those: number one, surgical volume is key. The higher the volume, the more practice everybody has in taking care of these patients, the more the care protocols can be, you know, standardized. And I think we see that those higher volume programs have the best outcomes. Capability goes along with that volume. There needs to be continual program assessment and quality improvement initiatives. I think the integrated congenital service line does allow you to do that. It gives everybody ownership, experience. It decreases our staff turnover. Our nursing staff turnover is the lowest in the whole system, which has 13 or 14 hospitals in the state. So all of this is how we see improvement in morbidity and mortality outcomes in congenital heart disease. Thank you.